In this video lecture, we'll review treatment options for post-traumatic stress disorder, including both pharmacological treatment options as well as different approaches to psychotherapy. Pharmacological treatment options for post-traumatic stress disorder tend to be focused on symptom relief. So, pharmacological treatments may be used to manage the distressing symptoms of post-traumatic stress disorder, but are often not sufficient to result in remission and help people achieve long-term improvement in their symptoms. The kinds of pharmacological treatments that are used for post-traumatic stress disorder are guided by the symptoms that an individual is experiencing. For example, because many individuals with post-traumatic stress disorder experience symptoms of anxiety, for example, panic attacks, anti-anxiety medications such as benzodiazepines may be used to provide relief for these symptoms of anxiety. However, the use of benzodiazepines for post-traumatic stress disorder shares the same limitations as use of these benzodiazepines for the anxiety disorders, including that they have a high risk that an individual will develop tolerance and they have a high risk of abuse, and also the fact that they can interfere with effective psychotherapy for post-traumatic stress disorder in the same way that they can interfere with effective therapy for the anxiety disorders. Another commonly used class of medications for post-traumatic stress disorder are the selective serotonin reuptake inhibitors. Many of the symptoms of PTSD are related to mood and anxiety, and we know that SSRIs are effective treatments for depression and for anxiety disorders, and similarly to the way that they can improve symptoms of mood and anxiety among individuals with major depressive disorder or anxiety disorders, the SSRIs can also help improve these symptoms among individuals with post-traumatic stress disorder. For example, these graphs present findings from a study of 187 adults who had been diagnosed with post-traumatic stress disorder. And on average, the individuals in this study had had PTSD for an average of 12 years. The majority of participants in this study were women, and over 60% of the individuals in the study had experienced either a physical or a sexual assault as the trauma that led them to develop symptoms of PTSD. This was a randomized controlled trial where participants were assigned to either receive sertraline, which is a selective serotonin reuptake inhibitor, or a placebo. And as you can see in these graphs, compared to placebo, the selective serotonin reuptake inhibitor resulted in significantly greater improvements in symptoms of PTSD, as well as improvements in symptoms of depression and increased quality of life compared to individuals who received a placebo. So the selective serotonin reuptake inhibitors can result in significant improvements in the symptoms that individuals with PTSD are experiencing. We also have a number of effective forms of psychotherapy for treating symptoms of post-traumatic stress disorder. The American Psychological Association strongly recommends cognitive behavioral therapy for post-traumatic stress disorder, particularly a form of cognitive behavioral therapy called prolonged exposure. Another form of cognitive therapy that is strongly recommended for PTSD is a treatment called cognitive processing therapy. There are also several conditionally recommended treatments, and one of the most interesting and controversial of these is a therapy called eye movement desensitization and reprocessing therapy. We'll start by talking about prolonged exposure. And prolonged exposure involves having a patient vividly reimagine their traumatic experience over a prolonged period of time. So similar to the treatments for our anxiety disorders, the core of prolonged exposure is exposure to the thing that is leading the individual to experience anxiety and related symptoms. However, unlike treating a disorder like a phobia or social anxiety disorder, we are not going to actually expose the individual to the trauma itself. So rather than exposing the individual to the thing that created this maladaptive fear response, we are exposing the individual to the memory of that traumatic event. And part of the idea behind prolonged exposure is that many individuals with PTSD are not only avoiding situations and cues that they associate with the traumatic event, but they are also avoiding thinking about the trauma exposure and thinking about the event itself. So in prolonged exposure, we combine imaginal exposure, where an individual repeatedly narrates the story of their trauma to the therapist. This is typically done as a short-term therapy, often over about 12 weeks. Typically, this is done in long therapy sessions, so about 90 minutes, hence the name prolonged exposure. But actually, very recently, so within the past week, a conference presentation comparing 90 minutes of prolonged exposure sessions to 60 minutes of prolonged exposure sessions found that the 90-minute sessions were not significantly more effective than the 60-minute sessions. So it will be interesting to see if findings from this brand new study affect how prolonged exposure is typically implemented in clinical settings. So regardless of how long the exposure is being done for, with the therapist, the individual is repeating their trauma narrative. So this serves several functions. One thing it does is similar to our exposure-based treatments for our other anxiety disorders, is it exposes the individual to the trauma memory and provides an opportunity for habituation to occur and for the conditioned associations that are leading to many of the anxiety symptoms to be extinguished. Another element of prolonged exposure is that elaboration of the trauma memory as the individual repeats it to the therapist during multiple sessions and repeatedly within a session allows for that trauma memory to become more elaborated and more complex, which often then leads to correction of inaccurate elements of the trauma memory. So for example, an individual early in therapy when recounting a physical assault may express guilt for not fighting back enough or believe that they could have been more effective in getting away from the individual who attacked them. Through repeated telling of their trauma narrative, they may include details, for example, remembering thoughts that they had about potential ways that they could escape that they were not able to, or potentially thinking about negative consequences that they might experience if they reacted in a different way. And these corrective beliefs could help them address feelings of guilt or shame related to how they responded to the trauma. In addition to these imaginal exposures to the trauma memory, prolonged exposure also typically involves in vivo exposures as homework, where the individual is exposed to situations or contexts that they have been avoiding that are related to the trauma. So similar to the kind of systematic desensitization that you might do with a specific phobia or a social anxiety disorder, the individual will identify situations or different kinds of stimuli in the environment that they are avoiding and engage in exposure so that those conditioned associations can be extinguished and to help eliminate the avoidance behaviors that often characterize post-traumatic stress disorder. I'm going to show you findings from a study of prolonged exposure. And in this study, there were 87 patients who had been diagnosed with PTSD, and all of the individuals in this study had met criteria for PTSD for a minimum of 6 months. This was a randomized controlled trial where individuals received 10 months of treatment, and there were 4 different groups of treatment. One group received prolonged exposure. Another group received a cognitive intervention, just cognitive restructuring. So they were using elements of cognitive therapy, such as helping people identify their maladaptive beliefs and challenge them, but without the exposure-based components that they had in the prolonged exposure category. There was a third group that received both prolonged exposure and cognitive restructuring. And then finally, there was a comparison condition that received relaxation training, but that did not receive any active treatment specifically for PTSD. So here you can see the self-rated global improvement in PTSD symptoms from the middle of treatment through 6 months after the end of treatment. Lower scores on this measure indicate greater improvement in PTSD symptoms. And you can see that all of the active treatments, so both prolonged exposure, cognitive restructuring, and the combination therapy, were more effective than the relaxation training, which was the control condition, at every assessment point. Up through 1 month post-treatment, the groups appeared to be equally effective for improving PTSD symptoms. However, as we look at more long-term outcomes, we see some evidence that the two groups that included prolonged exposure, so both prolonged exposure alone and prolonged exposure plus the cognitive restructuring, may even have resulted in greater improvement compared to cognitive restructuring alone. So this study suggests that both cognitive treatments and cognitive behavioral treatments, particularly prolonged exposure, are effective for improving symptoms of post-traumatic stress disorder. An interesting and controversial psychotherapy for post-traumatic stress disorder is called eye movement desensitization and reprocessing therapy, or EMDR. The core of EMDR involves an individual telling their trauma narrative and recalling their trauma memory while focusing on what they call a dual attention stimulus. So this might include the therapist moving their finger back and forth in front of the patient's eyes. It can also include auditory dual attention stimuli, such as using a metronome, or could even involve physical dual attention stimuli, such as alternately tapping on a patient's hand or on their knees so that they are getting physical sensation on altering sides of the body. And the idea behind EMDR is that symptoms of PTSD result from inadequate processing of the trauma memory, and that this facilitation of trauma memory consolidation and fixing these problems with the trauma memory is enhanced by bilateral activation of the brain that is caused by this dual attention stimulus. So there is evidence that EMDR is an effective treatment for post-traumatic stress disorder. However, there is a very active controversy within the field around whether or not the eye movements are necessary for symptom improvement. So some individuals believe that the dual attention stimulus is playing an important role in facilitating resolving the problems with the trauma memory that lead to the symptoms of PTSD. Other people note that the recalling of the trauma narrative in EMDR is an exposure-based therapy that on its own, even without the dual attention stimulus, could account for the efficacy of the treatment, and they believe that the dual attention stimulus is not actually necessary for the treatment to be effective. So a meta-analysis of 34 studies comparing EMDR to comparison conditions provides evidence that EMDR is an effective treatment for post-traumatic stress disorder. So in this graph, comparisons that are greater than 0 show that EMDR is more effective compared to the specified comparison group, and comparisons that are negative show that the comparison group is more effective than EMDR. So you can see that of these 34 studies, in the studies that compared EMDR either to no treatment or to a non-specific treatment like social support or general counseling, that EMDR was significantly more effective for treating symptoms of PTSD compared to these comparisons. There was no difference in the efficacy of EMDR compared to exposure-based treatments that were only imaginal treatments or cognitive behavioral therapy, including prolonged exposure treatments that included in vivo exposures. There was some evidence that the cognitive behavioral therapies and the exposure-based therapies that included in vivo components were more effective than EMDR. However, they were not significantly more effective. So we know that EMDR can help improve symptoms of PTSD. However, we still do not have clear evidence of whether this dual attention stimulus is necessary for EMDR to be effective.